A very good evening to everyone, and I bring greetings from my alma mater, that's Armed Forces Medical College in Pune. A very good evening to all the chairpersons and all the eminent panelists and the dear audience. In fact, I've been given very interesting topic, that's your thoracic trauma, which is close to my heart. And rightly so, and Einstein time saves nine. Probably I'll go a bit further. A lot of any line or tube in time saves millions. Right from the word go, when we start our medical career or the surgical career, we are always intrigued by very complex structure of the chest cavity with a lot of frightening vessels, heart, and all these vital structures, and we are always hesitant to tinkle with it in some way or the other. But as the days goes by, as our training goes by, I'll take all of you along with me with a small journey. Take you to 2019, my previous location, where I had a lot of experience with this all battle injuries like this gentleman who came with the blast injury. I would just request you to just focus on all these tubes and lines which has been placed. It's totally blasted off. The field medical officer very rightly, he's tried to tuck in whatever was possible, but yes, very rightly he put one tube in place. Whereas this second soldier who again had a blast injury, and the entire effort was probably wasted in hemostasis and because of this ghastly injury. And mind you, there is no tube in place. Another gentleman who was looking a little all right with a missile entry here in the upper arm and exit wound just in the infraclavicular region on the left side was talking when he came, and within half an hour, this soldier collapsed. Mind you, no tubes and lines. And another one, the last one, which I've taken as a prototype, was his bunker was totally blasted by the enemy shelling, and he was crushed under the rubble. It took almost 45 minutes to extricate him, and once he was taken out, and somebody rightly placed all the tubes and line in place. So what went wrong on those two patients, which was not there in the other two patients, is probably this what I strongly feel, these tubes and lines made the difference. So this gentleman who was good old weighing 70 to 75 kg and was rightly done by the initial treating doctor, his primary survey, which showed hypertension, and his secondary survey had, after stabilization, showed extensive defect in his chest wall with significant air leak. He had extensive surgical emphysema, and the rest of the cavity was more or less all right.
Hello, hello, hello,
And now
hello।
his CT scan
हाँ
showed
हाँ पवन सर आपका पार्सल लेकर आया हूँ।
his CT scan showed extensive pneumothorax on both the side, but rightly so the tube is there. He had collapsed lung, and bilateral the chest tubes were placed. He had extensive injury to the sternum, ribs, scapula, and the air was literally no, just under the skin. He had extensive hemothorax also on the right side, and his right tube was leaking extensively. So after stabilization, he was taken up for emergency thoracotomy. Like you can see here, the sternum is totally shattered, and uh, there was extensive air leak on the right side when we opened it up. And seeing after stabilization with ongoing fluid and blood resuscitation, he was further what we found, there was injury to the transverse upper lobar bronchus, and we attempted to repair it as early as possible, and that is the procedure done. But more importantly, what rather than our surgery, we strongly feel that what saved him was this bilateral ICTs and his endotracheal intubation done well in time by the primary care provider. And that was a transected bronchus, which was repaired on table. And later, uh, we found that after putting a lot of saline, there's a nicely expanded lung on the right side with hardly any air leak now. So there was a massive hemothorax, floating segments, large flail segment, air leak on the right side, and a large hemothorax. Subsequently, this patient had an uneventful recovery. On day 4, you can see the lung is now started to expand. On day 4, we also did the bronchoalveolar lavage with bronchoscopy, and his lung progressively expanded. On day 10, wound was looking all right with tube still in place, and day 16 shows further recovery and resolution on the right side. And a month later, this boy, though he's looking leaner now, but yes, all smiles at the end of the day. So, thoracic trauma, I mean, though looks very, devastating to look at, whether it's a penetrating injury, whether it's a blunt trauma, open chest wound, and it's a major cause of mortality and morbidity in our setting. Almost 25 to 30% mortality is reported in the case of polytrauma. There are traditionally we got all these life-threatening chest injuries which should be addressed immediately as early as possible, preferably during primary survey itself. Like a laryngotracheal injury, a boy who came to the trauma center a few years back, I still remember, with extensive emphysema of the face, neck, and chest. All he required was a tube here and two tubes on either side, and within 10 days, he was up and about. Whereas others may have lacerations of the trachea which require operative repair. The tension pneumothorax, again, putting a needle itself, like in this gentleman who seems to be hungry for air with tachypnea, tachycardia, a veteran who came to my last hospital, just by putting a large bore 16 gauge cannula made all the difference. But putting these lines in tube itself is not enough. Like this lady who came from 200 kilometers away, the doctors have rightly placed the chest tube with the pneumothorax still persisting. Obviously, there's a large leak. But yes, thereafter she came in the middle of the night and nobody took care of the draining bag. It was all ballooned out. But unfortunately, because of those odd hours and poor observation, she died of tension pneumothorax because there was no outlet in the bag and that outlet was clamped. Open pneumothorax again, all you need to do is now put a chest tube through a fresh stab wound rather than getting scared of these wounds and close the open wound gently. No need to get scared by either by the beating heart or expanding lung. All these wounds, all these injuries are manageable provided you use your common sense, just place a tube, occlude these wounds, and send them to the tertiary care centers as soon as possible. The flail segment, like the gentleman which I showed you earlier, they keep coming like this chap here. That is rightly he is on positive pressure ventilation. And also, there is a huge flail segment anteriorly with fracture of the sternum and contused underlying lung. And same is the case with this chap with the flail segment in the intramemory region on the left side. All they require is a treatment of the underlying lung contusion with judicious use of fluids and adequate analgesia, including thoracic epidural analgesia. Massive thorax is another major killer, but yes, rather than the traditional fear of initial lot of blood, more than 1.5 liter, we call it massive hemothorax. But surprisingly, as soon as we put a tube, because of the re-expansion of the lung, because of the tamponade effect of the lung, hardly less than 5% of these patients they require thoracotomy. Most of them they resolve just by placement of a tube. If I may so, even putting a small catheter into the pericardial cavity is also good enough for draining the pericardial tamponade, which may be picked up as early as primary survey while doing fast examination. That can save a life before the patient is transferred to a definitive care. Now, there are other injuries which may be missed during the primary survey. More so your blunt cardiac injuries, a traumatic aortic disruption, including tracheobronchial injuries. One should be careful, and especially when the diaphragmatic hernia, like in this case, when the stomach or the large jet is herniated into the left side of the bowel, before putting any lines or tube or the chest tube, thinking it to be a pneumothorax, especially if it is the stomach, you may perforate the stomach. So one has to be careful. That assessment has to be very judicious. Now, tracheobronchial injuries can be devastating at times if there is persistent large air leaks, but yes, with careful monitoring, very less patients, maybe one or two in 100, would require thoracotomies and repair of tracheal broken injuries. Like in this case, one can see that there was a large air leak. This patient had come to JPN Apex Air Trauma Center almost 10 years back, and there was extensive tracheobronchial injury with large air leaks. But because the patient was unstable, so unfortunately, the right pneumonectomy had to be carried out for this patient as a life saving or damage control procedure. Whereas another gadget available to us for treatment of this injury is your bronchoscope. There is a proximal and there is a complete transection of the trachea. So after initial evaluation, if the injury is limited, they are manageable just by non-operative measure. But like in this case, where the trachea is totally transected, he has to be explored and the surgical repair is mandated in this patient. Now, definitely a word about
It's a
placing a chest
landmark
tube.
for
We
the
have
fifth
been
intercoastal state.
traditionally, taught repeatedly to put a chest tube properly. As per ATS protocol, it's the fifth intercostal space just anterior to the mid-axillary line. So, adequate local anesthesia is given as deep as your parietal pleura because that's a pain sensitive, and your hemostat after giving a stab incision 3 to 4 centimeter is introduced on top of the rib just to avoid the neurovascular injury. Thereafter, once the parietal pleura is punctured, you expand the hemostat to create adequate space for the tube of and do a finger dissection, make a nice tract for the tube, introduce the tube, use ideally 28 to 32 gauge chest tube, and place it into the space created and direct it posteriorly and towards the dependent part. And thereafter, it needs to be connected to the underwater seal. The fogging of the tube signifies that you are in the right place. Apart from this, putting a needle for a suspected tension pneumothorax can be life saving. I had the opportunity to do in almost four cases by now, though you come across these cases very rarely today. But yes, traditionally we have been taught to put it into the second space. But yes, you can always go into the third, fourth, or fifth space in the mid clavicular line anteriorly in case a tension pneumothorax is suspected. So over that previous year, we had almost 83 patients of chest injuries out of a total of 1,500 plus cases, where they had all varied chest injuries and distribution of these chest injuries is given. What I want to highlight here is out of these 83 patients, intubation was done in 13 patients, needle or surgical kyphothyroidotomy was done in 4, and needle thoracocentesis is done in 2 patients, and as many as 60 patients were treated with chest tube insertion alone. And out of these 83 patients, just 3 of them, including the one which I showed earlier on, required emergency thoracotomy. And the 4 patients died, one because of the frail chest, another one, two because of ARDS following contusion, one as a result of extensive pelvic injury, a died of hemorrhagic shock. So the take-home message here is don't get scared by the chest injuries, whether they are penetrating, blunt, or open injuries. Okay, they are a part and parcel of polytrauma, and the initial stabilization requires just very simple procedures like your endotracheal intubation, just putting a needle or a tube into the cricothyroid, membrane or a needle or a tube thoracostomy to save these patients. And as we have been taught, as we have realized repeatedly, the most of the literature says more than 95%, but 90%, but I would no go further to say that more than 95% of these thoracic trauma patients are manageable without thoracotomies just by placing of just tubes and needles in various places as explained earlier. And the aim is to establish normal gas exchange and normal hemodynamics for this patient rather than doing any extensive or elaborate procedure initially. Thank you so much. I've finished. And once again, I thank all the panelists, chairperson, and the organizers for giving me this opportunity to share my views. Thank you so much.
Thank you, Dr. Pawan. We'll be taking question at the end of the session. Now I will invite our next speaker, Dr. Sandeep Jain. He is working as a principal consultant and also he is acting as head of the department in the Department of Emergency Medicine at Max Super Specialty Hospital, New Delhi. He is also an ACLS and ATLS instructor. And Dr. Sandeep Jain will be speaking on the topic surgical approaches for hemorrhage control in thoracic trauma. So I invite Dr. Sandeep Jain to start the session.
Thank you, Dr. Viplav.
Yeah, Dr. Sandeep Jain. You can proceed, Dr. Sandeep Jain.
Yeah. You can see my screen?
Yes, Sandeep Jain. Dr. Sandeep, we can see your screen. You can start. Yes.
Yeah. Good evening, everyone. Dr. Pawan has very rightly said the pretext for this topic, which is a very, very important topic. And because of this location and which occupies almost 25% of the body surface area, this is very vulnerable to various kinds of injuries. We know that, can you see my screen?
You can convert it into the slide mode, please.
Yeah, okay.
Yes.
Okay. So as he rightly said, the majority of the injuries which are from the thoracic injuries are managed by simple chest tube drainage. Almost 85% of the penetrating injuries and more than 95% of the blunt thoracic injuries can be managed by putting a simple chest tube. And this simple chest tube can be put up by any doctor who is even in the smallest of the centers. And only 15% may require some kind of surgical control. But as the surgeons who are taking care of the trauma patients, we need to learn about the various techniques, various approaches to control the hemorrhages from the chest trauma. It is worthwhile to just review the anatomy of the chest wall. As we all know, the viscera within the chest wall is enshrined by the rib cages, and there are the various muscles overlying it, which are very important for the function of the shoulder girdle. So we have the pectoralis major, serratus anterior, and the latissimus dorsi, which are required to be cut when we take the approach. So when we close the incision, this needs to be closed properly. When we look at the sources of the bleeding, there is a rich supply of the vessels and the major vascular organs within the chest cavity. When we talk of the blunt trauma, fortunately, it is more injuries are happening because of the damage to the intercostal vessels, maybe internal thoracic vessels, or because of the lung parenchymal injuries secondary to the fracture of the ribs. But in a penetrating injuries, we can get much more deeper injuries, which are injuries to the heart or maybe injury to the pulmonary hilum or to the great vessels. So when we look at the indications, we need to do it either in a setting of the emergency department where we need to do a resuscitation and try to save the life of the patient before we can go for a definitive surgery and as a damage control part. Commonly, urgent thoracotomy is also done after putting a chest tube. When we say that it is a massive hemothorax which is defined at more than 1500 ml of the blood coming immediately, or there is a continuous drainage of more than 200 ml per hour for more than 2 hours. But what we feel is not about the absolute amount of the blood which is coming out, but it is about the physiological status of the patient. So if the amount of blood is even less than 1500, the patient is continuing to be hemodynamic unstable, we have ruled out all other reasons of hemorrhage, then patient should go for a thoracotomy. Another indication would be when the patient is having a persistent hypotension and your fast is showing that there is a free fluid in the pericardial cavity. It is causing a cardiac tamponade. Again, the patient needs to be taken with thoracotomy. Sometimes later, if the patient has been stable and we have done the investigations, we have done the CT scan, and we find that there is a radiological evidence of a great vessel injury, again, a thoracotomy has to be taken up. So various surgical approaches which are being shown is an anterolateral approach, which could be done on either on the left side or the right side, and sometimes on the high anterolateral part. Second is a clamshell thoracotomies, posterolateral thoracotomies, median sternotomies with or without cervical extension, or a trapdoor or the book thoracotomies. And I will come to them one by one. Emergency department thoracotomies has been in vogue and has been used in the settings of the damage control surgeries. So patient comes in extremis, he shows no recordable blood pressure, there is no pulse palpable, but yes, patient shows some signs of life in the form of some eye movements or some spontaneous movements. So this patient needs to be taken up for emergency department thoracotomies by whoever surgeon is present and is trained in doing the thoracotomies. Usually it is done with the left anterolateral approach, and the objective here is to release the pericardial tamponade and control the cardiac hemorrhages, control the interthoracic bleeding, whether from the vessels or from the lung parenchymas, maybe even perform an open cardiac massage, and do a cross clamping of the descending thoracic aorta in very difficult to do a cross clamping because you need to dissect some aorta from the region, and most of the times when we do emergency department thoracotomy, it is being done with the ongoing CPR. It becomes very difficult to control the things. So the easier way of doing it, after opening of the chest, we can simply use our fingers. One of the assistants can put the fingers on the aorta and press it against the vertebral column till the patient is being resuscitated. Now coming to the anterolateral thoracotomies, the anterolateral thoracotomy can be done on the right or the left depending on the region where the injury is supposed to be. But by far, left is the commonest one, and it is a more utility incision. The incision is usually made in the supine position, and the patient lying supine with the arms abducted, and the incision starts from the fourth or the fifth intercostal space, starting from the mid-axillary line and going towards the external edge. Now, once we have made a skin incision, there are two ways of doing it. Either if the patient is, you have time, you can cut it under vision and do it with the help of a cautery. But more commonly, we can make an incision in the mid axilla and open up the chest, cut the intercostal muscles, and with the help of a Mayo scissors, once you enter into the pleural cavity, you can just extend it at the upper border, at the upper border of the lower rib towards the sternum. And once the sternum has been, the intercostal space has been cut up, the rib retractors is placed inside with the blade of the retractors in the two sides, the upper and the lower part, and the handle toward the edge of the table, so that in case required, the incision can be extended towards the right side. It gives a very rapid access to the left lung, to the heart, and to the aorta, and it can be easily extendable in case it is required to be extended to the other side. But the disadvantage is that it gives a limited exposure to the heart and the posterior thoracic structures. And if the care has not been taken care, then there could be an injury to the phrenic nerve as well. Now, once you entered into the thoracic cavity, we need to control the hemorrhages. If the injury is from the vessels, which are intercostal vessels or the internal thoracic, they can be simply ligated with the help of either a cautery or maybe you can use a sutures, whatever is available to you. In the cases of lung parenchymal injuries, there are various options available. Simplest in superficial laceration is simply overrunning with the help of a suture, what is called a pneumorrhaphy. If it is because of the penetrating injuries, where there is a tract which has been found within the parenchyma, a tractotomy is what is advocated. Tractotomy can be by putting the blades of the surgical stapler within the tunnel and then opening it up and then individually ligating up the bleeding vessels. If the staplers are not available, even the vascular clamps can be applied within the tunnel and it can be opened up. For the injuries which are not being able to control with the help of pneumorrhaphy or tractotomies, We can even do a simple resections in the form of wedge section by lifting up with the help of a lung retractor and filing the staplers, cutting up the part which is being affected. Or if it is a damage control surgery, maybe you can do a hilar twist by dividing the inferior pulmonary ligament and then twisting the whole of the left lung over its hilum. Hilar clamping can be done as you've seen in this picture. The affected lung is pushed towards posteriorly and inferiorly, and the assistant hand retracts the heart with a very gentle pressure, and the clamp can be applied over the hilum. In cases of a non-mechanical bleeding, some packing is sometimes being advocated. But the main problem which comes up when we manage these injuries is if the lung is keep on inflating, it is very difficult to control it. So if the anesthetist is competent, or if we had time initially, you could have used a double lumen endotracheal tube. If not, then we can converse with the anesthetist, and he can push the tube into the right main bronchus, which can deflate the lung. Or if that is also not possible, maybe for a temporary time, he can hold the ventilation, which will allow the lung to collapse and allow us to do the repair of this lung injury. Coming to the cardiac part, after opening up and entering the thoracic cavity, the pericardium has to be opened up. So the care has to be taken that it is opened up anterior to the phrenic nerve and starting from the apex toward the root of the aorta. Once the pericardium is opened up, the clots and the blood is evacuated from the pericardial cavity, and you need to identify the bleeding point. The simplest of the things and fastest which you can do is we can occlude with the help of a finger, which will reduce the amount of the bleeding, and then we can suture up the defect. If the defect is bigger and is not being able to be to control it with the help of a finger, maybe a Foley's catheter can be put inside the cavity, and it can be deflated to about 8 to 10 ml of the sterile water, and which can reduce the amount of the blood. We have not seen that the blood gets fully controlled by doing the maneuver, but yes, it reduces the amount of flow and gives us access for the repair of it. Temporarily, skin staplers can also be applied if expertise is not available to suture this defect. In cases of injuries to veins or to the atrium, a partially occluding clamp can be applied, and over this clamp, you can suture it so that the heart also continues to work, the cardiac output is maintained, and the repair is being done. The cardiography is being used where you use a non-absorbable horizontal matrix sutures with or without a pledget, usually in the cases of the ventricles. But one has to be very careful when the injury is near the coronary arteries, where you need to take a deeper bite to avoid compressing the coronary arteries and causing a cardiac ischemia. Now, in case you need to extend it to the right, which is usually the case when it is to the right side, the injury is to the right side of the heart, or onto the right lung, or just the complete mediastinal traverse, where you need to open up both the chest. The left anterolateral thoracotomy can be extended across the sternum to the right side in the fifth intercostal space, and it will completely open up. But here, most of the times when we transect the sternum, the internal thoracic vessels needs to be ligated, otherwise they will cause a torrential bleeding later on. The advantages of a clamshell thoracotomy is that it will give you wide exposure to both the lungs. You can access the complete heart and the proximal part of the mediastinum. But after the surgery has been completed, it causes a lot of post-operative pain, and there's a risk of external malunion as well. Another approach is a median sternotomy approach, which is the approach which is being used for the cardiac surgeries. Here, the incision is being taken from the sternal notch to the deep sternum. After the skin and the fascia has been cut off, the pectoral fascia is removed, and the periosteum has to be extracted off. With the help of a sternal saw, the sternum is opened up, and you put the retractor on the right and left side of the incision and slowly open up the chest. It gives a good exposure to the heart and the proximal blood vessels. It is very useful for when we have a precordial penetrating injuries or a superior mediastinal hematomas. But those who are not trained will take a longer time to open up the chest by this method, and obviously because it is anteriorly, nearer the neckline, it gives a poor cosmesis. There are more chances of sternal malunion, and infection in the form of mediastinitis can also be seen, especially in the setting of trauma when we are not very particular about doing a very meticulous, we don't have enough time to do a meticulous cleaning of that part. And it's also not good for the posterior mediastinum. If there is the injury to the innominate arteries or to the right subclavian vessels or to a common carotid arteries, this median sternotomy incision can be extended either on the supraclavicular fashion or along the anterior border of sternocleidomastoid to get the access. So in case of innominate artery or the right subclavian, it needs to be extended towards the right side, or to get the access to the left common carotid artery, you need to extend it towards the left side. High anterolateral thoracotomy is another approach which is advised, but it's very rarely being done because it is used only for controlling the proximal part of the subclavian artery when we have an injury. But the advantage is that it avoids opening of the chest and the postoperative morbid pain is reduced. So you need to do it in the second or the third intercostal space, take the control of the proximal part of the subclavian artery and take a separate supraclavicular incisions over the left side of the neck to get the distal control and do the things. The last one is the trapdoor thoracotomies, which is a very morbid incision and should not be done until as the desperate measures. It is a combination of the left anterolateral thoracotomy, midline sternotomy, and the supraclavicular extension. It just opens up the chest and gives you wide exposure to the left subclavian arteries and the vein, but causes a severe postoperative causalgias. Also, because of the traction on the part of the chest, the brachial plexus traction injuries are commonly seen with this kind of thoracotomy. Lastly, the posterolateral thoracotomy, which is the traditional approach to the chest, is used for in a very rare cases, especially only for the posterior mediastinal injuries in stable patients. So if we have a descending thoracic aortic injuries or the irregular injuries which are not bleeding very rapidly, this approach can be taken. It gives a good approach to posterior mediastinum, but the disadvantage is that it has to be put in a lateral decubitus, and the incision usually starts midway between the spine of the scapula and the thoracic spine, goes vertically down below the inferior angle of the scapula and then curves anteriorly toward the fifth intercostal space. And that's a traditional approach. So if we look at what incisions we should be using in the trauma, this simple algorithm which has been given in the Mattox textbook of trauma is very helpful. So if you have a EC thoracotomy, that is emergency department thoracotomy, usually the approach is from the left anterolateral side. If the patient comes in extremis where the injury side is not known, then you start with the left anterolateral thoracotomy and may consider extending it to the right side, make it a clamshell thoracotomy. In cases of urgent thoracotomy incisions where there is continuous bleeding going on, in case of the anterior pericardial stab wounds, a median sternotomy is the incision of the choice, while for all other incisions, the anterolateral thoracotomy on the side of the injury has to be adopted. In the cases of posterior mediastinal injuries or the intercostal injuries, you may consider posterolateral thoracotomy in the stable patient. If we go by the specific injury patterns, for the injuries of the ascending aortas, innominate arteries, right subclavian artery, or the common carotid artery, the median sternotomy with the neck extension is what is to be used. In cases of left subclavian arteries, the high anterior thoracotomy is a separate supraclavicular incision, or rarely the trapdoor thoracotomy incision is being used. In cases of descending thoracic aorta or the interthoracic left subclavian arteries, left posterolateral thoracotomy is to be used. While for the pulmonaries, for the cardiac injuries, for the intercostal vessels or interthoracic vessels, the anterolateral thoracotomy is the approach. So if we look at the various gamuts of the various incisions which are available, if you see that left anterolateral thoracotomy is the one which is more likely to be used, being a more versatile incision and can be extended. And that is what an ideal approach should be, which gives us a rapid and a wide access and should be able to get access to almost all areas of the interest. So conclude that selection of the incision is very important for a good exposure. Left anterolateral thoracotomy is the most commonly used approach in majority of the trauma patients because we get these trauma patients in unstable conditions. The approach will be influenced by the physiological state of the patients as well as the experience of the and the training of the surgeon involved. And lastly, because various muscles which are being cut are the major muscles of the shoulder girdle, a meticulous layered closure of all the muscles is paramount importance to get a good functional outcome. Thank you so much, and I finish it. And thank the organizers for giving me this opportunity to speak in front of you.
Thank you, Dr. Sandeep. It was a very knowledgeable presentation from your side. Now I invite Dr. Shamita Chatterjee to introduce our next lecturer.
Thank you, Dr. Biplav Mishra. I would now like to invite Dr. Ramila Ratnayake from Sri Lanka. He is the consultant surgeon at the Army Hospital at Colombo and also an adjunct associate professor at the Uniformed Services University of Health Sciences at USA. Dr. Ramila will be sharing with us his experiences on vascular injuries in the military services and how he would like to translate that experience into civilian injuries. Dr. Ramila, welcome, and please take the stage.
Hi. Can I see my slides?
Yes, you're visible. Yeah.
Hi. Can you hear me?
Yes,
Okay.
you are. Yeah.
Thank you for inviting to the Trauma 2020 virtual. Special thank goes to the doctors Dinesh Bagaria and the team at Indian Trauma. And the warm greetings from Sri Lankan College of Surgeons. Today, my topic is combat vascular trauma lessons learned and transferable civilian practices. There's nothing to disclose. And this picture depicts the oil painting by Canadian war artist Richard Jack. It indicates the great misery at war. But the war field is attraction to the surgeons because number of casualties we see at each time and the severity of the trauma at the battlefield is a great attraction to the surgeons. And this intricate relationship between the surgeons and the war has been eloquently elaborated by one of the World War I surgeons, George Markins, in his special lecture to the Royal College of Surgeons. And I quote him, one surgery can afford more material and more varied nature than many years of experimental work. So how it differs, how the trauma differs, how war trauma differs from civilian practices. We are in the battlefield, we encounter more high energy, high lethality of wounding from the gunshot injuries and the fragments. And there are sometimes there's multiple causes of wounding, such as from the burn injuries and blunt injuries are sometimes associated with the penetrating trauma. And always there's a persistent threat to the caregivers that we have to work with the sometimes bullets going around us and the range of blast within the healthcare facilities. And most of the time we have to work in austere setting with a lack of instruments, and sometimes the theater facilities are not ideal. Sometimes we have to work in a poor light to avoid attraction from the enemies. And sometimes the resource persons are not available. Sometimes you have to be a thoracic surgeon, the vascular surgeon, and the plastic surgery that has to be done by the single surgeon. And transfer to the next level of your victim is not always guaranteed. Sometimes in the tactical situation, you have to keep extended period till the time is favorable to transfer to the next level. So these the battlefield conditions are nicely compiled by one of the trauma pioneers, the Howard Champion, in his J-Trauma article, A Profile of Combat Injury. And this J-Trauma article by the Benjamin Starnes, ex-colonel, now the chair, the vascular chair at the California University, compiled the experiences of the war regarding to the vascular extremity trauma. And he concluded by saying the experiences gained should transfer to the next generation of surgeons who are indoctrinated for the battlefield. Here I show you the trauma or the war field structure. By the necessity of the war field, it is segregated into the levels or echelons. And the level 1 is the place where we do the attend to the life-threatening injuries such as hemorrhage. And the last decade of war in the Middle East, that the hemorrhage control has the tourniquet came from the last resort of the hemorrhage control to the first aid measure. I will later explain how it happens. And the level 2 is the closest facility where the helicopters can be landing, where we do the next frontier in the extremity trauma to mitigate the ischemia by performing four-quadrant fasciotomies and informing the temporary intraluminal shunting. And the level 3 is the in-theater, the robust facility where we can do the damage control, definitive surgery. In the case of extremity vascular trauma, it is the most of the time we have to resort for reverse saphenous vein graft most of the vascular injuries due to the severity of the trauma. And out of the theater facilities, the level 4 or level 5, where we do the sophisticated, advanced reconstructive surgeries, soft tissue reconstruction, and the orthopedic reconstruction and the rehabilitation of the patients. So I will elaborate a few of the things I have described. The combat tourniquets came from the last resort to the first aid lifesaver due to multiple reasons. The first thing is at the start of the war in these recent wars, the researchers understood that about 13 to 20% of the potentially preventable deaths due to the hemorrhage happens from the extremity tourniquetable trauma. And with that knowledge, they have got the teams to upgrade the then available tourniquets to the currently available combat application tourniquets. And when after that, the policymakers make it a rule that every soldier deployed to the battlefield should train in tourniquet application, when to apply the tourniquet, when not to apply the tourniquet, and when to remove the tourniquet. And also every deployed soldier has been equipped with the upgraded tourniquets. And with these factors, the tourniquet became a lifesaver in the contemporary battlefield. And the John Craig from the US Army extensively studied, and they have shown tourniquet application at the early, before the onset of shock, has a life-saving advantage. And this indicates the importance of the rapid transfer in the battlefield. This article by the Russ Kotwal analyzed the Secretary of Defense mandatory of transferring the injured soldiers within 60-minute cutoff time. It has happened in the 2009 and indicated by the blue line. So after the 2009, you can see in the yellow line, the percentage of soldiers transferred to the definitive care after the injury is increased to the 75% by the 2013. And also in the dotted line indicate the case fatality rate reduction. From start of the war, it is at around 20, and by the 2013, it reduced to the unprecedented 8.7. So how this was happening is, one reason is the rapid transfer, other thing is the advancement of the care at the battlefield in the front line for the injured soldiers. And the Professor Todd Rasmussen and team extensively investigated about the temporary intravascular shunting as a damage control vascular adjunct in the extremity vascular trauma. And they have proven in their studies the proximal shunt in the femoral and the popliteal arteries has an advantage, and even they can keep for extended period of patency, maybe 12 hours or more. But sometimes in the distal below the trifurcation, this advantage may not be seen. So how civilian practices differs from this combat experience? In the civilian setting, we see more blunt injuries after the motor vehicle accidents. And our facilities in the civilian setting is more resource. We have got advanced imaging and sometimes theaters with very modern theaters with sometimes hybrid facilities. And we have got all our specialized colleagues, thoracic surgeons, vascular surgeons, orthopedic surgeons, and the plastic surgeon in a single facility. But the flip side is with this hyper specialization and the advancement of the healthcare in our countries is the number of vascular injuries exposed to the surgeons. So young surgeons coming out these days, the exposure to the vascular trauma may be minimal, and we have to find ways and means to keep this very valuable skill set for the next generation. But said that sometimes as civilian surgeons, we have to expose to this extreme condition. Here I show in the 2019 in Sri Lanka, there was a multiple blast happened during the Easter day, and killing hundreds of people and injuring more than 500 people. And in this kind of situation, we are exposed to the mass casualty scenario. Multiple numbers are coming, and with the penetrating trauma similar to battlefield. And sometimes, especially in the low and middle income countries, we have to work in a rather the austere and the remote and the rural setting. And sometimes we have to transfer in a next to the next level of care after doing the damage control surgery, similar to the battlefield. In our Sri Lankan experience with the delayed transfer in the battlefield in comparison to the Middle East, it has been close to 6 hours, the transfer time. We have identified as a research team, there's a need for prioritization, special cohort of limb injuries that has got a very rapid ischemic insult. So we have identified few variables that is helpful for to tag this cohort of extremities for expedite care. So popliteal region with the meager collateral circulation, we have identified it is a worst case scenario. And we have tagged complete ischemia, that is when the pulses and the Doppler is absent, we tag it as a complete ischemia, is one of the other variables we use for the prioritization. And combined arterial and venous injuries, when we see the surgery, it is a bad combination for the salvage of the limbs. And the skeletal trauma is a surrogate mark of the soft tissues injury and the collateral circulation damage. As a research team, we have emphasized the need for more emphasis to study the effect of collateral circulation in the limb salvage, and we are working and published extensively in this regard. So with this knowledge, we are working on forming an algorithm. Here we have used the pulse, the distal ischemic stated by using the pulse and Dopplers. And we have used the anatomical zone, popliteal being the worst case scenario. And the time to transfer to definitive care, more than expected time, more than 2 hours, taken as the criteria for in this algorithm. And we have created the clinical guidelines to be used in the battlefield in future. So after identifying the prioritizing the needed the extremities, we are subjecting these to extensive 4-quadrant fasciotomies. There's ongoing discussion about how to train the surgeons to get the maximum outcome with the fasciotomy training, as well as temporary intravascular shunting. And then we expediently transfer to the next level of care for the definitive reconstruction. So why we all should be at war? The famous saying by the Hippocrates, he who wishes to be a surgeon should go to war. As I explained in my first slide, there's a multiple casualties coming into the during your war experiences, and the severity of trauma is unparalleled to what we see in the civilian practices. And with that, we have gained enormous amount of experiences within very short period of our work at the battlefield. And definitely this knowledge can be transferred to our civilian colleagues and the civilian system later after the war. And other thing is, during the wartime, there's a great depth of surgeons to the national militaries. So there's a call for the civilian surgeons to be part of the military reserve and help and be familiar with the conditions that they are going to expose when the war comes, maybe during their lifetime. And so another experience by the UK the Navy surgeon, the Alistair Walker, he analyzed the experiences of the surgeons during the wars from World War II to the current wars, and he realized after each war there's a rapid decline of the knowledge, skill, and the expertise of the war, managing war injuries by the surgeons. And when we start the next war, the knowledge has to be relearned, and in the meantime the soldiers can die. The case fatality rate is higher, than the previous time of the war. And there's an ongoing discussion about how to mitigate this workers' dip. And one of the suggestions is the military-civilian partnerships sharing the common goals and common training and the common research goal to benefiting both the military system and the civilian system. So there's a calling for creation of global military-civilian trauma surgery consortium for collaborative research and the training. As Professor Kenneth Mattox said a few days back, we are a special breed with a special genes, working against a common enemy, that is trauma pathology, with a great feeling of brotherhood. My special thank to and the gratitude to Professor Norman Rich from the Uniformed Services University, the pioneer veteran from the Vietnam War and the pioneer in the Vietnam Vascular Registry, and his ongoing and continuous support to my research in extremity vascular trauma. Thank you.
Thank you, Dr. Amila. It was a really enriching experience hearing you. I think we can take the questions for all the three speakers now. I would request Dr. Gyan Saurabh to take us through the questions.
Thank you so much, Dr. Shamita. So with this excellent session, I would like to invite questions from all the participants and faculty here. We have covered up three very important topics, including the role of ICD, surgical approaches for hemorrhage control, and an excellent talk by Dr. Amila. So may I request our faculty members and the participants, if there is any question they would like to ask to our three speakers?
Can I ask a question, Dr. Saurabh? Dr. Bhoi here.
Yeah, I can see, sir. Please go on, sir.
Yeah. This is like just question to the panelists, to various the speakers. How often you are using Reboa in the ER and in the pre-hospital care setting?
Okay, so would you like any particular speaker, Dr. Pavan, Dr. Sandeep, or Dr. Amila?
Anybody can take. That's
okay.
not.
Sir. Yeah, so may I request Dr. Amila to answer a question of Dr. Bhoi?
Actually, in the Sri Lanka, we are still to start Reboa in Sri Lankan hospitals, but I'm working with the EVN team with the leadership of Cal Hora, and the current status is at very early, and there's an ongoing discussion about how useful the Reboa is going to be. But in the battlefield, the George Dubos and the Professor Todd Rasmussen and experimenting is used in the front line at the field, and they have proven in the experimental level it is successful, as well as in the London trauma with the leadership of Professor Karim Brohi. They are doing these things in the London ambulance system. So there's a great potential for the saving the lives in the front before coming to the hospital, pre-hospital level, and hopefully with the experiences gained and the improvement of the equipment, there's a great potential for Reboa to be used in future in the front line as well as the hospitals and the pre-hospital level. I hope I have answered the.
Yeah.
Yes, sir. Thanks, Dr. Amila. And is there any
Hello.
other? Yeah, please.
Dr. Gyan,
Yeah,
I'm Dr. Biplab Mishra.
Yes, sir.
I just want to clarify something. Dr. Bhui was asking about Reboa. Let me clarify that Reboa is mostly used for torso trauma, that is abdominopelvic injuries mostly. Its role in thoracic injury bleeding is very low. And second, we have not started doing Reboa or using Reboa in our trauma center yet, though there are some projects being planned by Dr. Mohit Joshi, but it is still in the pipelines, but we have not yet manifested those programs.
Thank you, sir, for adding on to the information. And you are very correct in saying that probably not many centers have been doing it so far. Any other question from any of our expert panel? Any comments regarding the thoracic trauma and the wonderful session we had so far? Elsewise, I would like to give the mic over to Dr. Abhinav. If there is none,
there was one question from ma'am only.
Okay.
She was asking regarding the when with the a patient who is with the chest trauma with an ICD in situ and is on ventilator, and what ventilatory setting do you prefer as a trauma surgeon? We generally prefer, and this was question to the sir Sandeep sir, if you can answer, sir.
Yeah. So normally what we do is when the patient comes with a chest trauma and already have a chest tube in place, most of the times the patient is already having an underlying lung contusions present with it. So what we set up is we do a pressure assist control mode for this patient, and we keep the pressures, the P plateau pressures should not be more than 30 to 35. That's what we are trying to keep. In addition to that, we are keeping the PEEP levels around 5 to 6 only, not more than that. But more importantly, what we are taking care is the judicious use of IV fluids. We should not be giving too much of IV fluids. And that is what we have found that it gives a good result to us.
Ma'am, you're kindly
Yeah.
yeah.
Yeah, thank you, Sandeep. I got my answer. Yeah.
Yeah. I think, Abhinav, you can thank the chairpersons and close the session.
Yeah.
Thanks everyone, Dr. Pawan, Dr. Sandeep, Dr. Amila, Dr. Sandeep Kumar, Dr. Biplab.
Thank you.
And Dr. Shamita Chatterjee for the wonderful session. And with this, we end this session. And may I request
Thank you.
chairpersons of the next session to be invited by the organizing committee. Thank you so much.
Thank you.